I'm Tawara Good, Director of the National Center for Cultural Competence at Georgetown University Center for Child and Human Development. I'm going to share with you several models of looking at cultural competence and linguistic competence as they relate to health promotion training. I'd first like to present to you a rationale for cultural competence in primary care. One of the first things we look at is responding to current and projected demographic changes. There have been significant changes on demographics overall in the United States since the 1990 census. I'm going to share a little bit more with you as we continue. Another is to look at eliminating the longstanding disparities in health and mental health status of people in the United States. We know that clearly since 1998, the Department of Health and Human Services has established 6 areas of health disparity, including infant mortality. What's very exciting about this goal to eliminate racial and ethnic disparities is that it's a very bold public health message in which we indicate that incremental decreases are no longer acceptable, and the overall goal is to eliminate racial and ethnic disparities in health. Another reason that we think about cultural and linguistic competence in primary care is to improve the quality of services and outcomes. It's very important as we think about racial ethnic disparities that access point at the very beginning at the front desk serves as a barrier to many individuals who are indeed seeking care. A fourth reason that we look at in terms of a rationale for cultural competence in primary care is to meet legislative, regulatory, and accreditation mandates. Most recently, there's been a great deal of emphasis on legislative requirements. That's from the federal government and also at the state level, in terms of looking at how we address the needs of culturally and linguistically diverse populations. We see this in grant applications. We see this in contracting language. We also see this in accrediting agencies, American Psychological Association, American Nurses Association, and others within the healthcare arena who are indeed looking at cultural and linguistic competence as key skill sets for their practitioners. A fifth one that we can look at is gaining a competitive edge in the marketplace. And again, this is really very critical. Those organizations and agencies are posturing themselves to, again, meet the demographic needs of the United States population. And again, attending to cultural and linguistic differences can be very effective in gaining that competitive edge. Lastly is to decrease the risk of liability and malpractice. We know from the literature that healthcare practitioners, and physicians in particular, who are most likely to be sued are those who do not communicate well with their patients. And that's when English is the first language, and that is indeed an absence of cultural barriers. One of the reasons that we listed earlier was looking at current and projected demographic changes. We know that according to census data and other data most recently collected, the United States is much more diverse than it has ever been. Since 1990 to 2000, we've seen a significant change in demographics. About 1/3 of U.S. population describe themselves as being from culturally, racially, and ethnically diverse groups. This slide basically shows us some trends from the year 2002, and we look at the top 10 countries of birth for immigrants to the United States, again in the year 2002. There were a little over 1 million individuals that were admitted from countries such as Mexico, India, People's Republic of China, Philippines, Vietnam, El Salvador, Cuba, the Dominican Republic, and the Ukraine. And again, these are significant trends that we see across the country, and it's changing many states and communities. Other data from the U.S. Census indicate that there are a significant number of individuals who speak a language other than English at home. And from 1990, we saw a significant increase to 2.5 million U.S. residents who report that they speak a little to no English. As we're thinking of designing training in particular for health promotion and risk reduction, it's important for us to consider the cultural factors that influence diversity among individuals and groups. Time precludes us going through all of these internal factors, but I will highlight a few that may be of interest. Oftentimes people confuse cultural, racial, and ethnic identity. We see this frequently in our training activities across the country. As we know, culture and race and ethnicity are all very different things. I'd love to share an example from my colleague who was providing training in an audience that was not so diverse, at least racially not so diverse. And as my colleague addressed issues pertaining to African Americans, he tended to glance over at this particular individual, and he did that periodically during the session. On break, the participant came up and said, you know, I appreciate all the personal attention you're giving me. However, I'm Panamanian, and I mean it. And what had happened in that very simple interchange is that my colleague realized that he'd made a big assumption. He made an assumption that he knew something about her identity based on who she looked like racially. While indeed she was indeed black, her country of origin was Panama. Very, very, very different culture, different language, different experiences. And so it's very important for us to attend to those factors, that cultural identity and racial identity and ethnic identity may be very different. So we have to probe as we're thinking about design and training that's going to reach a variety of populations. Other internal factors that we can think about are tribal affiliation and clan. That may indeed be the identity for a number of people. Also, again, looking at nationality. Acculturation is very important as well. Different people have very different experiences in this country, and the extent to which they have acculturated, especially as we look at health beliefs and practices, is really very critical. There are lots of other things here that are very key, looking at language. Again, whether or not people prefer to hear information, receive information in English and or their language of origin, very key factors. Looking at health beliefs and practices, very key. What is a perception of a particular group and or individual in terms of what may have caused their illness? Also looking at very much what may get them better. All of these are very critical factors as we think about this. Numerous other things, looking at age, life cycle issues, looking at their perception of health and mental health. All of these are variables that need to be considered in designing training that's going to be effective with diverse audiences. There are other cultural factors that influence diversity among individuals and groups, and some of these are external factors. We have a number of them listed here, and again, time precludes going through all of them. However, one that you should think about that will be very important is looking at institutional biases. It really is very important to understand what is the perception of your institution, your organization, et cetera, within the communities that you're trying to reach. Sometimes it may be very positive perception and sometimes not. I've been made aware of a couple instances in which an individual who's engaging in community outreach encountered someone who was very upset about the care that a family member had received at this particular hospital. It's very hostile, very angry. And in pursuing what was so upsetting to this individual about the care that a relative indeed had received, a colleague understood that indeed the person felt that they'd been discriminated against. What's so very powerful about this experience is the experience had happened 10 years before. And this was the perception of this person about that particular institution. It's very important to know these things. While probably many things had changed within that community, things that probably changed within an institution, still, this person was holding on to that initial encounter from her relative. And so, again, these things are very key as we look at it. We also know from the literature that at least in terms of encounters, that one dissatisfied customer can indeed impact 16 others. So looking at how your institution, agency, or organization is perceived may be very important. It may mean the difference between whether or not you're a credible voice within that community or whether you're not. There are other cultural influences on beliefs and practices related to children with special health care needs or children with disabilities that may be very important, and particularly looking at issues such as superstition, malevolent forces, religion, and familiar folklore. Again, these things may be very key in how people practice health beliefs, how they approach care, how they access care. These things, again, are really very critical.